Welcome everyone. I'm Holly, one of the in-house vets at IMV Imaging, and I just wanted to say thank you for signing in this evening and welcome to the next in our series of monthly IMV Imaging Academy webinars. This evening I'm delighted to welcome Dr. Richard Ewers. Richard is a clinical associate professor at Nottingham Vet School. He was a senior veterinary surgeon at the PDSA and joined the University of Nottingham in 2009. Richard is involved in the development and delivery of small animal clinical practice through the PDSA clinical rotation and specifically the teaching of diagnostic imaging. Richard is an RCVS advanced practitioner in veterinary diagnostic imaging and is especially committed to furthering diagnostic imaging from a first opinion perspective. Tonight's webinar has been pre-recorded, so unfortunately there will be no opportunity for a Q&A session, but contact details are very easy to come by on our website. I suspect you've already had some of them, and at the end of the webinar, if you would like to get in touch with any questions, do feel free. So without further ado, I'm delighted to hand over to you, Richard.
Thank you, Holly. Hello, and welcome to this webinar on how to get the most out of our thoracic radiography. In this session, we're going to consider how to select the correct cases and plan investigations to get the best results. We'll also look at how to obtain the best quality radiographs. We'll then spend some time thinking about interpreting radiographic lung patterns. But before we go any further, we need to consider an important question, arguably the most important one we can ask ourselves about radiography. That is, do we really want to do it at all? If we make the wrong decision and X-ray a case which is unlikely to give useful results, we've wasted our time, our client's money, and put our patient through an unnecessary procedure. We've also used radiation unnecessarily, which is a safety problem. Also, we need to think about whether we want to use other imaging modalities, such as ultrasound and CT. Despite the growth in use of these alternative techniques, radiography is still a key imaging technique for the thorax, and most thoracic imaging cases will be radiographed at some point. So how are we going to decide about whether we need to do radiography? These radiographic or Röntgen signs will help us. These are the features of an organ or structure that we can find out about from a radiograph. Indeed, these are the only features of an organ or structure that we can find out about. We'll see these are essentially structural or physical things. So that means that radiography should only follow a thorough workup of the case, including history, physical examination, and perhaps other tests, which suggest a specific change of this kind within the body. It's also a good idea to reserve radiography for those cases where the clinical signs are either severe or persistent or recurrent despite treatment. For example, if we radiograph every dog that comes into our clinics with a mild cough for the first time, we'll get a lot of normal radiographs. On the other hand, if we reserve our radiography for those cases where the cough is severe or doesn't go away or keeps coming back despite any treatment we give, then we'll get a much better diagnostic return, as these are going to be the cases which are more likely to have one of the structural changes we've just looked at. So when we've decided that radiography is likely to be helpful for a case, how can we make sure we get the best quality images? Restraint is very important with the thorax, due to respiratory as well as voluntary movement. We've got a number of options. General anaesthesia has the obvious advantage that the animal loses voluntary control over its movements. Also, with an endotracheal tube in place, we can oxygenate the patient more effectively. Finally, we can control respiratory movement, for example, by inflating the rebreathing bag to obtain good inspiratory views. On the other hand, sedation may be safer in some cases, for example, with heart or pleural space disease. In these cases, an opioid alone, for example, butorphanol, may be enough to take the edge off the animal to allow us to persuade it to lie for radiography. Sedation may lead to reduced respiratory effort, so sedated patients should always be carefully monitored, and some flow by oxygen should always be considered. Also, this reduction of respiratory movement may make obtaining inspiratory radiographs more of a problem, unlike with GA, where we can control this. Using physical restraint alone seldom gives a good result, except in very sick animals. We should never be hand-holding patients for radiography, except in exceptional circumstances. And using sandbags alone on an uncooperative patient won't normally give good quality images. Indeed, this may stress the animal more than giving some careful sedation. On the other hand, if we have a dyspneic cat and we feel we really need that single view to assess for the presence or absence of pleural disease, letting it relax and hunker down in a plastic or cardboard box on the X-ray table may allow us to get a satisfactory DV view with minimal stress. We then come to actually making the radiograph in the X-ray room. And here I find this mnemonic useful. Pink camels collect extra large apples. It may sound strange, but this phrase reminds me of the things we need to do when actually making a radiograph. And not only that, but also it gives the most efficient order to do them in. So, pink is for positioning the animal, camels for centering the primary beam, collects for collimating the beam, extra for setting the exposure factors, large for labeling the image, and apples for that final check that there are no artifacts in the primary beam before we leave the room to make the exposure. For example, no sandbags or drip lines. All of these aspects of radiography are important to obtain a good quality radiograph. But as George Orwell tells us in Animal Farm, all of these things are equal, but some are more equal than others. And for thoracic radiography, two key aspects of technique are positioning, particularly avoiding axial rotation, and making the exposure at peak inspiration. In terms of positioning, in the UK, we tend to prefer a right lateral view for the reasons on the slide. We'll see that with this dog, we've pulled the limbs forward, the forelegs forward to reduce superimposition on the thorax, ensured the neck is not flexed, and put a foam pad under the sternum to avoid any axial rotation. When it comes to assessing the radiograph to make sure we've avoided axial rotation, the most reliable way is to look at the heads of the ribs to see if they overlie. Don't look at the bodies of the ribs themselves. They will never all overlie due to the shape of the thorax and beam divergence. So it's the most proximal part of the ribs where they come off the spine to look at. Just here, and here, and here. Here are a couple of examples. On the left, the rib heads overlie nearly perfectly, so there is minimal axial rotation. Again, here and here. On the right, however, there is a marked separation of these rib heads. So there is significant axial rotation, here to here, here to here. In terms of centering and collimation for the lateral view, the beam is centered just caudal to the most caudal edge of the scapula and about halfway up the body. Now, if we center in the right place and collimate cranially to the thoracic inlet, and we can feel the manubrium here, we should get the right amount of the body exposed caudally, including the whole of the diaphragm. And dorsoventrally, we should collimate to the thoracic spine and the sternum. It's always important to take an orthogonal view. There are pros and cons to both dorsoventral and ventrodorsal views. The dorsoventral view is safer if the patient is having difficulty breathing, and it's easier to interpret the cardiac silhouette. On the other hand, in the ventrodorsal view, we can see a little bit more of the lung fields, which might be helpful. The principles of positioning, centering, and collimation are the same as for the lateral view. In this dorsiventral, we've made sure the dog is symmetrical, with the spine overlying the sternum to avoid any axial rotation. And again, the centering point is just caudal to the caudal border of the scapula in the midline. Collimation is again to the thoracic inlet cranially and laterally to the skin edges. Sometimes it's important to take two lateral views as well as a dorsiventral or a ventrodorsal. This dog had an abdominal mass and we were checking it out for lung metastases. In this right lateral, there's not much to write home about really. Perhaps something going on around the apex of the heart here, but not really a lot to see. This is the same dog on the same day, but now we've laid him on his other side, and immediately we get a lot more diagnostic information. The reason we get this effect is that when we place an animal on its side, particularly but not only under general anaesthetic, the lowermost lung will rapidly collapse and can take on a near soft tissue opacity. If we have a soft tissue nodule within this lung, we won't see it as there is little contrast with the surrounding lung. Place the animal on its other side and this lung lobe is now uppermost and will reinflate. The nodule will be surrounded by aerated lung and we'll see it. So which views should we take? For routine thoracic radiography, including cardiac cases, the preferred views are a right lateral and a dorsiventral. As we've just seen, when looking for METs, we should take both laterals and a dorsiventral or ventrodorsal. It doesn't matter which. If we want to evaluate the lung specifically, it's also a good idea to take both lateral views, as we'll always see more detail in the uppermost aerated lung, and then take a VD. If we take two views, a lateral and a DV or a VD, and we're not sure what's going on, then, well, we can always take the other lateral, and that may help us. So we've looked at PINC, Camels, and Collect. We now need to consider extra, that is, exposure factors. Avoiding movement blurring is a key objective in veterinary radiography. What can we do to avoid this? As we've already seen, restraint is very important. It's also important to use a short exposure time, for the thorax a 30th of a second or less. And this should be achievable with modern high-powered X-ray units. It's also a good idea to use a grid to control scattered radiation for body areas thicker than 10 centimeters in thickness. This is particularly important with CR cassette-based digital systems, which are particularly sensitive to scatter. Finally, we need to routinely make exposures for the thorax at peak inspiration, although to be fair, this may well be unrealistic in panting animals. Here's an example. This is a lateral radiograph of a normal dog's thorax. Well, I mean, it's a normal Cavalier King Charles Spaniel. And surprise, surprise, it had a heart murmur and was coughing. Now, clearly here we suspected a structural change within the thorax, so we did some radiography. And just look at this cardiac silhouette. It fills the whole of the height of the thorax. And look at the trachea. It's really elevated and rammed up against the spine with marked compression at the bifurcation. And if we look at the caudodorsal lung lobes, there's an increase in opacity compared to the cranial lobes. Oh, probably pulmonary edema. So this dog looks like it's in congestive heart failure. But is it? If we look at the diaphragm, its shape is generally rounded dorsally, and it meets the spine at T11. This is an expiratory radiograph. On the right-hand side, we have the same dog on the same day. We've just taken the radiograph at peak inspiration this time. We can see now the dorsal diaphragm is flattened and it meets the spine at T12 to T13. The heart is still very big, but not as massive as in the expiratory image, and the trachea and main stem bronchi are less compressed. Also, the caudodorsal lung fields now have a normal opacity. So yes, clearly this dog has heart disease, but it's not in congestive heart failure. so the coughing is probably caused by the airway compression. So it's important to recognise if our thoracic radiographs are inspiratory or expiratory. Interpreting an expiratory radiograph without allowing for this can lead to a misdiagnosis. Okay, so hopefully we've now produced some good quality radiographs. Let's consider a few general points of interpretation before looking at the lung patterns. An interpretation of thoracic radiographs is not easy, and this is partly due to anatomy. If we think about it, the anatomy of the thorax consists of concentric rings. We have the thoracic wall on the outside. Then as we go inward, there's the pleural cavity, which surrounds the lungs, which in turn surround the heart and the mediastinum. This means that whatever direction we direct the X-ray beam, we will go through all of these layers to reach the middle and then through them again on the other side. So this produces a lot of superimposition of structures on the image and makes interpretation more challenging. There are a couple of principles of interpretation that can particularly help us in the thorax. The first is the principle of border obliteration. Across the Atlantic, this is often referred to as border effacement, and it's often called the silhouette sign in the UK. But to be fair, I always struggle to remember what's a negative or a positive sign, so border obliteration makes more sense to me. This simply means that if we have two structures of the same radiographic tissue type, so gas, fat, air, soft tissue, fluid, bone, or metal, if they're touching, we won't see the join, and their borders will not be visible at this point. So, the cat on the right has pleural fluid, and this is touching the heart and the ventral diaphragm. As fluid and soft tissue have exactly the same radiographic opacity, they're the same radiographic tissue type, and appear identical on a radiograph, we can't see these as distinct structures. Their borders are obliterated. On the other hand, on the left in the dog's thorax with the METs that we've seen before, we see the soft tissue lung nodules as they are separated from the heart by aerated lungs. So we can see the borders of the nodules overlying the cardiac silhouette. Another useful appearance in the thorax is a mass effect. This means that if we have a mass or enlarged organ, it will displace other structures away from itself. So the cat on the left has a cranial mediastinal mass, and this is displacing the trachea dorsally away from itself. When we look at the dorsoventral or ventrodorsal view of an animal, the concept of a mediastinal shift is also useful. Again, if there is a mass effect on one side of the thorax, then the mediastinal structures will be displaced away from it. Conversely, if there's a reduction in volume on one side of the thorax, the mediastinum will move towards this. So in the cat on the right, the left lung has completely collapsed, and the right margin of the cardiac silhouette is now nearly on the midline, as the mediastinum has moved over to the left. We've already said that placing an animal on its side leads to the lowermost lung collapsing. So it makes sense to take our dorsoventral or ventrodorsal views first. Then we know that any lung collapse we see can't be caused by earlier positioning. Right, let's now consider the lungs, and in particular, those dreaded lung patterns. When we look at normal lungs in a radiograph, we don't see individual lung lobes. Rather, we see an overall lung field. Within this, we can see some normal lung markings. To help us think about what we're seeing and how disease can affect lung appearance, it's worth considering the components that make up the lungs. We have the larger airways, the bronchi, leading to smaller airways, bronchioles, and then to very small alveoli. Blood vessels run along the bronchi, and then there is the interstitial tissue, the connective tissue binding all these together. Now, when we get lung disease, there are different characteristic radiological appearances depending on which component of the lung is affected, and we refer to these as lung patterns. So we have a bronchial, alveolar, vascular, and interstitial lung pattern. We'll look at each of these in turn. I'm not going to give you lists of differentials for each pattern. We can easily look this up. What we're going to do is to concentrate on recognizing the characteristic appearances. This representation of the lung may help us. We have larger airways with blood vessels running along them, and then smaller bronchioles leading to alveoli. Now, this is a schematic representation. Clearly in the lung, we don't have airways like straws with bunches of grapes at the end. In the lung, the alveoli fill nearly all of the space between the airways, even the larger bronchi. But we can get an impression of the normal appearance we get with the larger airways, for example. We have a soft tissue bronchial wall with air in the lumen and air in the alveoli outside, around here. So we see soft tissue circles or parallel lines, depending on if we're looking at transverse or longitudinal sections. And along these larger bronchi, we can see blood vessels, soft tissue or fluid circles in transverse sections or lines in longitudinal views. However, we don't see the smaller bronchi or alveoli, as their walls are too thin to show up on a radiograph, and there's air inside and air outside. So we will see some normal markings in the lung. The key is to determine if they're normal or abnormal, in which case we have a lung pattern. So what do these normal markings look like? And we can see some in this radiograph. The yellow arrows are pointing at airway markings. The two on the left show transverse sections with thin soft tissue circles with air inside and air outside. And on the right, we can see two parallel lines representing the bronchial walls in a longitudinal view. The blue arrows show blood vessel markings. On the right, two rounded, solid soft tissue fluid circles in transverse section and branching solid lines, a longitudinal section on the left. So how will this normal appearance be affected by disease? If we think about the airways in a normal lung, we can see the walls of the larger bronchi, but not the smaller bronchioles, as we've just said. If we have bronchial thickening, then the walls we would normally see are thicker. Also, as the walls are thicker, the cutoff point of wall thickness below which we can't see the walls is now further down the airways, meaning we can see bronchial markings further out towards the periphery of the lung. So here's a typical bronchial pattern, with thick cuffs and lines which extend right out towards the edge of the lung. We often refer to this appearance as tram lines and donuts, for obvious reasons. Here is normal lung again. The other thing that can happen with the airways is mineralization. In this case, the bronchial walls will have increased opacity, but have a normal thickness. And again, the markings will be seen further out towards the periphery, as we're not solely relying on soft tissue for their visibility. So this is a lung with bronchial calcification, and we can see many thin-walled radiopaque bronchi. So that's the bronchial pattern. What happens if we have alveolar disease? Here we can see some fluid or cells in the alveoli. The first thing we note is that there's an increased opacity in these alveoli, so there will be an increased opacity of the lung. Now this can be marked as the alveoli make up such a large part of the lung volume, and the lung may actually take on a soft tissue or fluid opacity. The other thing to notice is that some alveoli are filled and others are not. So this can result in a heterogeneous, patchy nature to the increase in opacity. Something else happens. Remember, we don't normally see smaller airways on a radiograph as their walls are thin and they have air in the lumen and also air outside them. Now we have a soft tissue fluid opacity outside them. So this will contrast with the air in the lumen of these smaller airways, and we will see them. We refer to this appearance as air bronchograms. The key feature to differentiate an air bronchogram from a normal bronchus is that we can't see the soft tissue wall of the airway as a separate entity in an air bronchogram. This will merge with the surrounding soft tissue fluid opacity. Also, we may identify small radiolucent patches representing unfilled regions of alveoli, which we call air alveolograms. So here is a typical alveolar pattern. The lung has a marked increase in opacity, which is patchy or fluffy in appearance. As the lung has taken on a soft tissue fluid opacity, we lose the borders of the cardiac silhouette and diaphragm, so we have border obliteration. And here we can see air bronchograms, branching lucent lines representing the air in very small airways out towards the periphery. And note, we can't see the airway walls as separate structures. We can see them going right out towards the periphery here. So much for the alveolar pattern. What about the blood vessels? We see blood vessels in normal lung as soft tissue fluid circles or branching lines, which taper towards the periphery of the lung. We normally see these around the lung hilus and up to around 2/3 of the way out to the periphery. In the lateral view, the main place to critically assess the vessels is where they're seen crossing the cranial aspect of the cardiac silhouette. In the lower left image, we can see the right cranial lobar artery and vein. The vein is ventral to the artery. The key thing is that these two vessels should be roughly the same size. If we want to get some idea of absolute size, their diameter should be no greater than the width of the proximal part of the fourth rib. In the dorsiventral or ventrodorsal view, we normally look at the caudal lobar arteries and veins, where they cross the ninth rib. In this view, the vein is medial to the artery, so veins are ventral and central. Again, these vessels should be roughly the same size, and their diameter should be no more than roughly the width of the ninth rib where they cross it. So here are our normal vessels, which we'll see coursing along the larger airways. One thing we might see is that veins are bigger than the arteries. Here is a case. We can see the right cranial lobar artery and right cranial lobar vein. And if we look carefully, we can see that the vein is significantly bigger, the ventral vessel significantly bigger than the dorsal artery. This is outlined here. And this is typically the sort of change we'll see in early left-sided congestive heart failure. Here are our vessels again. Another thing we see is that both vessels are big. Here is an example. And both of these cranial lobar vessels are enlarged. So this could indicate, for example, overcirculation of the pulmonary vasculature. Again, our normal vessels. Blood vessels may be smaller than usual. This is a change in the appearance of the vasculature, so this also counts as a vascular pattern. In this dog, the cranial lobar vessels are difficult to see and are very spindly. The cardiac silhouette is also small, and this dog has hypovolemia. That just leaves us with an interstitial lung pattern. Disease affecting the connective tissue of the lung. There are two types, a diffuse pattern, sometimes called unstructured or fine structured, and a nodular interstitial pattern. With a diffuse pattern, there is a generalized or regional infiltration into or thickening of the interstitial tissue. As this is only a small part of the total volume of the lung, there will be only a modest increase in lung opacity on the radiograph. This dog has a diffuse interstitial lung pattern. I would agree, there are clearly other aspects of the appearance that we might be concerned about. However, if we take a close look at the caudal dorsal lung, there is a generalized increase in opacity, which has a rather hazy appearance. We can still see the pulmonary blood vessels, but perhaps not as clearly as we normally do. And we can see the cardiac silhouette and the diaphragm. The interstitium is also where nodules grow. For example, metastases or abscesses. But remember, there are several other possible differentials. This dog had a large ulcerated mammary carcinoma, and we can see the multiple nodules in the lung. It's important to recognize that when looking for lung nodules, we can only see soft tissue spheres within the lung on a radiograph when they're around 0.5 centimeter in diameter or bigger. So if we see isolated rounded lung opacities smaller than this, they can't be METs, for example. So we've looked at the 4 lung patterns. But before we finish, there are some pitfalls of interpretation we need to avoid. In dogs, the caudodorsal lungs are very close to the spine, right up to the tip. However, in cats, they diverge slightly from the spine, from around T12, due to the larger sublumbar muscles in this species. Also, some lung patterns will appear with age. For example, many older dogs will have a mild bronchial and/or interstitial pattern. So if we see this in an old dog, it could well be incidental, whereas the same appearance in a young animal would be more worrying. You'll remember we said that we cannot see rounded lung nodules on a radiograph until they're around 5 millimeters in diameter. In this dog, we can see multiple isolated rounded opacities, which are smaller than this. And from what we've just said, they can't be soft tissue spheres. They can't be, so what are our options? Well, they could be soft tissue or fluid cylinders, that is, end-on blood vessels. So we're looking down the length of them. But some towards the periphery are quite large and wider than the adjacent blood vessels that we can see. So that doesn't work. The only other option is that they're visible because they're not soft tissue at all. And these are small areas of mineralization within the lung. And the higher radiopacity means smaller structures can be seen. These are variably referred to as heterotopic bone or pleural plaques, and they're incidental findings, particularly in larger breeds of dog. It's important not to mistake these for metastases. If there's a lot of fat in and around the thorax, this will increase the opacity of the radiograph, so obese animals will have more opaque looking lungs. Also, don't forget lung collapse as a cause of increased lung opacity. In the image on the right, we have collapse of the right middle lung lobe, and this has taken on a soft tissue fluid opacity. And there's border obliteration with the right cardiac silhouette and a small mediastinal shift to the right. So how can we go about trying to work out which lung patterns are present? I find this flowchart helpful. Firstly, we need to decide if there's an increase in opacity in the lungs. If there is, we need to decide if this increase could be mainly caused by increased bronchial markings. If it is, then we have a bronchial lung pattern. If not, we next need to decide if we can see the soft tissue structures in and adjacent to the lungs. If we can't, then the lung has taken on a soft tissue fluid opacity and we have an alveolar pattern. If we can, then there is a lesser increase in opacity and we have an interstitial pattern. Independent to this, we can look to see if the pulmonary blood vessels are visible. and then we can assess them if they are too big or too small, in which case we would have a vascular pattern. Now, it's important to recognise that lung patterns are often mixed, with two or more of the above. However, we shouldn't use this as a cop-out to avoid specifying what's going on. It's usually possible to work out the main components of the mixed pattern, and this will greatly help us with our differential. Before we finish, here are a few questions to review the lung patterns. I'll give you about 15 seconds to think before giving the answer. So which is the main lung pattern in this case? So this is an alveolar lung pattern, where the lung has partly taken on a soft tissue fluid opacity, leading to the characteristic signs. What about this one? This is a typical bronchial lung pattern. And what about this one? Here, the right cranial lobar vein is significantly bigger than the artery, so this is our vascular lung pattern. And finally, which species is shown here? The caudal dorsal lung edge slightly diverges from the spine in this case, so this is a cat. I hope you found this podcast useful to help your interpretation of thoracic radiographs and particularly lung patterns. This summary gives the key points. It's important to select our cases carefully and plan our study. The usefulness of a radiograph is directly related to the diagnostic quality of the radiograph. So, do all we can to get good quality. Remember, border obliteration and the mass effect are useful signs to look out for. And lung patterns are useful for finding out what's happening in the lungs. And remember that if you have a mixed pattern, make sure you work out the main patterns present. And finally, don't forget that some lung patterns, some lung markings are normal. So try not to overinterpret the lung appearance. If we do all of this, we should all get a good return for our thoracic radiography.
Thank you very much, Richard. That was a great illustration of a very practical approach to interpreting thoracic X-rays. I certainly will be, and I think everyone else will be feeling a lot more confident about interpreting those dreaded lung patterns in the future. If anyone does have any questions, please don't hesitate to get in contact. You can get in touch with IMV Imaging via our Facebook group if you're not already members. Please look us up. It's IMV Imaging Small Animal Veterinary Group, via Twitter, or of course directly via the website. So once again, a huge thank you, Richard, and thank you to everyone who's signed in to listen and watch this evening.